Good afternoon, everyone. So, the important talk which you are going to discuss is principles and practical implementation. So, first part I will just cover the stewardship, why it is important, why we want to do it, and then we will cover some of the cases which bedside we can apply in our day-to-day practice. So first I want to acknowledge the maximum material. If you want to learn in detail, you can get from this WHO toolkit, which is very practical kit which they have developed. Then CDC, IDSA and American societies. These are the one who are pioneers in antibiotic stewardship, and most of the principles they have actually studied and evidence based is from that side. So you can reach, it's free of free literature. So today we are going to discuss importance, global burden, core elements of ASP, how to implement, and monitoring and outcome. So if we start, what is antimicrobial stewardship? So as sir asked you, stewardship means supervise. Here you have to be very particular about you have to be responsible, and you have to be using the appropriate antimicrobial or antibiotic, as he discussed. Especially we are discussing antibiotic here, to improve the patient outcome. So what does that mean? So it is not a rocket science. It is very simple science. Actually, you should know which drug you are adding, right drug, what is the dose you are giving, what timing you have started, what is the duration you are going to cover, and choosing your patient. This will cover in the cases. When I start the cases, we will discuss these points in detail. So why you want to do, why we are discussing at all this topic? So we are main important, the benefit, evidence-based benefit which we found is the development of antimicrobial resistance. We are all aware that we are living in an era of MDR thing. So we want to reduce it. So stewardship is the one of the pillar. Which is the other pillar? One pillar is antibiotic stewardship. Which is the other pillar? More important. If you want to reduce the antimicrobial resistance, you want to improve the patient safety and clinical outcome, you want to reduce the healthcare associated infection, you want to reduce the cost and prevent the antibiotic effect in future. So this is antibiotic stewardship program. Which is the other program without which the ASP will fail? Basic program which you do daily when you enter. Hand hygiene, infection control practices. So that is the backbone. That has to be done, and then this will be adjuvant for that. So no need to say that this is the global problem, and this is some recent article in Lancet has said that there will be around 8.2 million deaths in 2050 if we continue in the same way. They have some statistical model, prediction model with artificial intelligence they have used, and they have predicted this kind of death. And if you see, India is high on cards, complete brown is there. So we will be the highest hub for the resistant bugs. You are all aware about this escape. What is escape? So these are the key resistant pathogens which we are facing in our unit. Which is the most common? Acinetobacter. So you are getting Acinetobacter, you are getting ESBL and multidrug. So these are the agents we will need to address. So how do we address? So first element is leadership and commitment. So how to design? I'll just give the administrative. Hospital has to support in this initiative. So first thing is you have to have a dedicated team for formation for the stewardship program. There are a lot of elements which is required. You may not be lucky to have ID physician in every hospital, but if you have one, he is the one of the principal leader or associate leader with the clinician. We don't have a luxury of clinical pharmacist most of the time. So that is one of that. They have made the design this guideline as per the American heart test, like I told, SHIA guideline. In India, we have to modify it according to our local resources, our staff, and what is your institution policy and accountability. So this is the first core element which is required. So we started working on this. We talked with the medical administrator. We got the ID physician. we took a microbiologist. Very important team player is a microbiologist in your team who is going to give the great feedback. And then the how the program runs, how the quality people will assure that prospective feedbacks from our program. And then we have to involve the pharmacist, we have to update him what is her responsibilities, and the infection control nurse. So this complete group of people will plan and design the for your antibiotic stewardship program. So you have to start with the awareness. You have to make your nurses, your staff, everyone aware about first the infection control practices and then about the antibiotic stewardship. So most of them will not be knowing the antibiotic. It's not about I know everything. It's not about that. Antibiotic stewardship starts from the very basic, from the nurses to the top level. So they should also understand what antibiotic is on. They should be able to stop you from prescribing unnecessary antibiotic. Like they should make you alert. Ki it is day 10. Should we continue this? And they can count the number of days. So they are the first person who actually give the antibiotic to the patient. So sisters has to be empowered. They should say that I have not taken blood culture. I don't want to give antibiotics. So you have to ensure that they take the blood culture before you prescribe. Right? So all these things can be from the grass level. We can form a team and plan things. So they track the antibiotic prescription pattern. So this has to be tracked. Monitor the resistant trends. So this is what your microbiologist will give. Every 6 months we get our Antioca antibiogram. What is antibiogram?
Resistance of antibiotics.
So what are the 3 common infections in ICU you get? Pneumonia, VAP, catheter associated or catheter linked, or surgical site you may get post-op sometimes, or urinary tract most common. So you have to you have to give at least 30 isolates are when they are 30 isolates, minimum 30 isolates to make a antibiogram. So they will give you the pattern of resistance, and you will according to that we sat with the microbiologist, and designed our antibiotic policy. If what organism we have, what should be our first line therapy, what should be our second line therapy. So if the patient develops a nosocomial infection, we know what is our drug to be given. Then measuring the days of therapy, this is very important. How many days, which infection. So initially it was thought that 7 days, 14 days, these are not the magic numbers. This is no longer true. You have to continue for 7 days. If the patient is improved on 3rd day, so there is no need to continue, just I want to continue 7. You can de-escalate, you can switch to oral. If he is microbiologically improved, if he is blood culture negative, clinically stable, no need to continue that meropenem for 7 days. Even after 3rd day you can de-escalate to the according to your. So that is missing. So after 48 to 72 hours, the reassessment, re-look or look to the patient is missing. We are very aggressive about inotropes. We rapidly, in the morning we come, we try to de-escalate, we give fluid. In weaning also we are very aggressive. Chalo, take the patient on pressure support, give the trial. But in antibiotic we are loose. Okay, today is 5th day, let's see at 7th day. Or today is 3rd day. We are not that aggressive. But that aggressiveness has to come. Then outcome to stakeholder, regular audit and feedback is important. Then actions which we can take is what we did is you can have a formulary restriction, but this is difficult sometimes because in corporate hospital, depending on your institute, the objection may be raised by the physician. They will not be ready for this restriction. They cannot say, they will say nobody can challenge my prescription. So in that case, what we can do is you can introduce a form for pre-authorization, write the indication why you want to start. So some form, why this was started. So antibiotics starting for the form, not for all antibiotic, for the form which are restricted antibiotic. So are you aware about the aware classification? WHO aware classification. So this is what is the problem. So we are not aware about aware. So aware is access drugs like penicillin, amoxicillin, nitrofurantoin, which are the baseline, which has less potential to develop the resistance. Then there is a watch drug like piperacillin, tazobactam, which can develop. We want to keep the watch on them. And reserve drugs are only indicated in the proven cases where you have microbiology data proven, where you want to treat with cholesterol, you want to treat with life-threatening infection. So this is, we have to become aware, and we have to switch from restrict to watch to come to access. That should be our goal when we are following the antibiotic stewardship program. So we have to be doing this audit. How many times we follow the microbiology data? How many times we are switching from IV to oral? Are we really assessing at 72 hours or third day? Are we really assessing? So infection prevention education are we giving? So these are the actions. And restriction means you don't allow to start until there is pre-authorized by, say, ID physician will write only. Ceftazidime avibactam, normal physician cannot write. It's a reserved drug. He has to be signed by the ID. So you have to get the pre-authorization. So this kind of strict stewardship can be put. If your MDR are touching 90, you are getting XDR and you are in very bad shape, probably that might work. So depending on your institute, you have to follow, and it should be smooth process, including all. So multidisciplinary team has to be involved. The most difficult part of the team member will be old physicians, surgeons who are not willing to change. So that is important. You have to take them in confidence, tell them that single dose of prophylaxis is enough, clean surgeries. So you don't require to continue for 48 hours or for 3 days. So that kind of concept, develop your institutional guideline, and for this you require the administration support. Another important, most important, now they have switched from antimicrobial to, now they are talking of early, that is diagnostic stewardship. So how you can prevent starting the antibiotic? If you have good diagnostics with you, if you have rapid diagnostic testing, if you know that it is influenza, viral, there is no bacterial infection, no need to start. If you know it is a dengue fever, no need to start empirical antibiotics. So this is what rapid diagnostic test you should promote. You should start thinking which test I can do and what is the turnaround time, how quickly I can get the results. So targeted therapy based on culture results only you should aim for. Another important is fever of unknown origin. There is no symptoms of urinary tract infection, there is no tenderness, pubic tenderness, but invariably we send urine and we get some pus cell in that, and we may start treating it. So that is the most important hurdle in antibiotic stewardship. So don't send unnecessary urine culture. So stop sending urine culture if you are not clinically suspecting UTI at least, because urine may grow colonizers which you start treating the patient with. So obtain the culture, this is most important. Always obtain culture before starting the antibiotic, except certain life-threatening condition which we will discuss in case. And then develop the site-specific antibiogram. So I remember one surgeon giving cephalosporin sulbactam for the meningitis. He said, "No, I want to give cephalosporin sulbactam only," and that doesn't cross blood-brain barrier. I took hard time to convince him in the institute. It doesn't cross blood-brain. It is not going to work. But that is how you have to educate them. You have to educate. Site specific, which site it is, the antibiotic, PK, PD, you have to be very aware. In ICU the things are totally different. So you have to be aware about the pharmacokinetic dynamic distribution, how much dose is required. So that will be a separate talk. Then treatment optimization, as I already told, de-escalate to narrow spectrum as early as possible. Switch IV to oral whenever appropriate, and establish the duration of limits for common infections. So 7-day therapy, 5-day therapy, 3-day therapy, you have to decide on that. Avoid duplicate antibacterial coverage. Despite knowing it, we do sometimes cover. So anaerobic cover especially. So if you are giving intra-abdominal infection, I am giving meropenem. So should I give metrogil? So if I am standing on academic platform, I will say no, because it covers, meropenem covers most of the anaerobic, and I don't require additional metrogil. But on ground sometimes I add. So that disparity should not be there. Then about the your another redundant cover like piperacillin tazobactam also covers the anaerobic, so it doesn't require metrogil. So this type of combination you should try to avoid. No need to add antifungal if you don't have evidence. days of therapy per 1000 bed days. These are the indicators. Now, how do you do the indicators? We Dr. Upendra has done one study with under Sir's guidance and all. They found the daily defined doses of the antibiotic which we are giving earlier before implementing these kind of policies, and then after implementing 6 months we have seen the difference. How much is the daily defined dose of that antibiotic? So daily defined dose is a WHO standard defined dose in a day. How much dose has to be given? So you can compare as per the 100 bed days. So we did that for our IPD patient, and we find that daily defined dose of, suppose your reserve drug is high, meropenem, colistin, this is going high, and that means you are utilizing more. So you have to look in and your infection control practice, your antibiotic policy, and then again check it next month. So if comes down, that means is working. It is one of the indicators, key performance indicator. Then antibiotic appropriateness, whether it is appropriate, resistance pattern will change. So the Klebsiella, which was multi-drug, it become multi-sensitive. So your policy is working. Then another important is C. difficile infection rate. This is very significantly increased if you have a problem with your infection control and antibiotic policies. So high chances of C. difficile infections. If the rate increases, it signifies that your stewardship requires reassessment. And then healthcare associated infection reduction. So these are the key performance challenges. As I told, clinicians are resistant to change. They will not like to, if you suggest somebody no, use this, so it will be difficult. So what you have to do is maximally educate, engage them and discuss with them. Then you have to have a balance, the safety and stewardship sometimes. Like in liver failure, I will tell, liver failure patient may land up in sepsis in a moment. So there we cannot hold their hand for stewardship and tell them, okay, don't give him ceftriaxone. So you have to decide. So that you have to balance that thing in a particular group of patients. So as I told, it is not rocket science. It is preserving antibiotic today, and it's everyone's responsibility, because antibiotic is something which you give to a single patient and it will affect the community. So if I give him, the patient from Finland came here, Finland travelers came here, and they had pani puri here because India pani puri is famous. So before coming, one I don't know, Hinduja, they got the study to get the rectal swab and this thing E. coli, which was sensitive to all. And then when they traveled back after this pani puri and diarrhea and this thing, so they found that it became ESBL. So it spread in the community internationally also. So one person can affect the other also through water wastage and other mechanism. So antibiotic therapy has to be, and if you take an antibiotic, how many days it takes for your gut to recover? Suppose I take an antibiotic, how many days it takes?
3 to 4.
No, 3 to 4 days is a myth. It takes 6 months to 9 months to develop that complete gut microbiome to what it was earlier. So that is the problem. So you have to decide. If you take an antibiotic, you decide you are changing your gut micro, selection pressure increases, and you may develop multi-drug resistance. So this was I was talking about. This is in our NTU first choice drugs. You can see, I think its slide is thoda sa ye, but reserve group में meropenem, colistin, fosfomycin, teicoplanin, linezolid you have to hold. ऊपर देखेंगे तो levonorofloxacin is there, clindamycin is there. There are excess. They can be used for your infections and this thing, and then piperacillin and all these are the watch group. This is one of the madam student has done. This tells our you should know your antibiogram. So that's why we are using what we are using, antibiotics. So Acinetobacter is in our ventilators. CVC we are getting Klebsiella, and this we are getting E. coli in the catheter. These were the study done by Piyush. His thesis was there. So we found that this you come to know your antibiotics. So this policy may not work in other hospital. So if somebody says I will not repeat study, you should repeat study, because your organism flora will be different. So this is our epidemiological pattern. So you can treat better. This is the Upendra, which has done impact of antibiotic stewardship. So what interventions were done? A team of physician, intensivist, specialists, as I told, these all met, and then antibiogram prepared. Then they reviewed the audit meeting, strict hand hygiene, aware classification, hospital anesthesia, all these things were done. And what they found, this is the reduction, 18% reduction in GDD of meropenem, polymyxin, all these hydra, and even days of therapy was reduced. So this was the positive impact which ASP can have. So now going to the second part of the thing, where we'll discuss the cases. So how what is the use? You are talking about institute, and what is I am supposed to do. So as a physician, critical care physician, so first my thing, how can I help making a diagnosis? So first thing, whenever you go to the patient, first thing you should ask is whether is it an infection before writing an antibiotic. Is it an infection? Is it severe one? That question you have to ask. Then second is how likely this patient is. Ask for the comorbidity, ask for the previous admission. If the previous admission within 90 days hai, as I told, the gut microgram takes 6 months. So previous admission में अगर उसको meropenem मिला है, there is high chances that he will have MDR. बराबर. So you have to have asked for that. Then don't forget to take appropriate specimen culture. Appropriate word is important. So blind cover, stop blind cover कि send urine, send blood, send trachea, send ये. No, wait, don't send urine. Urine नहीं लग रहा है. Send blood, send tracheal secretion. So that is what you have to take, appropriate and rapid diagnostic test, and rule out the non-infectious mimic, colonizer, especially asymptomatic bacteria in the urine or asymptomatic pyuria in the urine should not be treated. When will you treat? Which condition you will treat? Pyuria is there. Which condition? So pregnancy, then if the patient is going for urological procedure, some retrocatheterization, or where you colonizer can land up there, you can empirically use the antibiotic. So you have to decide and use the rapid diagnostic test as we are doing here. So risk factor, clinical condition, drug intervention, these are the situations where you cannot wait. So this is like patient with acute bacterial meningitis has to receive the antibiotic as early as possible, because there the mortality is high. So there is only 4 or 5 classes. A severe community acquired pneumonia, bacterial pneumonia, either you have to give the antibiotic even if you are not getting the sputum. Many times you don't get sputum, but you cannot wait ki I am not a culture, I will not start. So empirical antibiotic has to be started. Necrotizing fasciitis, life threatening, here you have to start. Febrile neutropenia, you have to start the cover. So these are the some life threatening condition where you may require the immediate therapy. Choosing the appropriate antibiotic, as I told, from our local antibiogram spectrum of you have to decide whether this antibiotic will cover the gram negative. I am not thinking gram positive. So don't put the ticoplanin or antifungal. Correct route and renal and hepatic clearance in ICU is important. So always check the eGFR. So one of the cases, the young patient meningitis staph was detected, and he was getting vancomycin 1 gram BD, and still the fever was on 7th day. What is wrong here? 7th day still fever and still is not recovering. So do you think it is a wrong antibiotic? Do you think it is a resistance? Do you think it is inappropriate dosing? So his eGFR was calculated was 600. High eGFR, it is normally 100. So in medical condition, you have to look for the distribution GFR for, especially for vancomycin. We are worried about renal shutdown. But what about the renal is normal, patient on CRT or somewhere? So you have to give additional dose to maintain that trough level. So these are the drugs which require therapeutic drug monitoring, and they will not work if you keep it below the drug. So the dose was increased by ID. He made it 1 gram 8 hourly and fever stopped. So it was a simple thing. So you have to look for choosing the right antibiotic, and the dose is important. This is what a simple mnemonic which we can remember. Microbiology, mind me, always writing antibiotic, mind me. Microbiology guided therapy whenever possible. Indication should be evidence based. You have to write, you should be able to write the indication. You should be starting the narrowest spectrum possible. Dosage appropriate. Every day think of weaning, like we think of weaning, can we stop the antibiotic? Don't wait, don't remove that barrier of 5 days, 7 days, 10 days. Remove that barrier. Look, microbiological improvement, clinical improvement, stop antibiotic. Minimize duration or ensure monotherapy. So enough of my talking, now it's your talking. So can you read out the case?
A 72-year-old woman with history of frequent urinary tract infection who has chronic suprapubic catheter to manage neurogenic bladder associated with multiple sclerosis present for follow-up. A urine culture obtained 3 days earlier documented 10 to the power of 5 colony factor unit of pan-sensitive Escherichia coli. A patient denies fever, dysuria, suprapubic discomfort, flank pain or any other symptoms. Suprapubic catheter was placed in past month.
So what should be done? So which of the following management is most appropriate? Nitrofurantoin for 7 days, amoxicillin for 7 days. These are, nitrofurantoin is excess drug. Amoxicillin is also excess drug. Ceftriaxone is excess drug. Fosfomycin is, I think, watch drug. Ciprofloxacin is watch drug. And no treatment. So how many of you raise your hand for no treatment? No treatment. So asymptomatic है तो नहीं देना है. और still you will give nitrofurantoin. Most of them. Catheter है ना?
10 to the power 5.
10 to the power 5 है. So
Asymptomatic, no treatment.
asymptomatic, no treatment. So that is what is stewardship. So here you have to keep a watch, and you have, the patient doesn't require the treatment. It is asymptomatic, but it is not. If you suppose undergo some procedure later on, then you may have to consider. What will happen if you give? It will become resistant. Second, Sunil.
65-year-old woman, otherwise healthy with no comorbidities. She presented with the persistent shortness of breath and cough. She has recurrent bouts of pneumonia confirmed by migrating obesities on chest X-rays that have been treated with multiple courses of antibiotics. She has intermittent fever and cough. She has no sick contacts, sputum production or hemoptysis. CT scan visualizes area of consolidation. Surgical lung biopsy shows no evidence of infection or malignancy, but reveals patchy alveolar filling with loose plugs of granulation tissue.
So therapeutic option for this patient will be what? What should be given? So what is the diagnosis? What is your diagnosis? Want to go me back? What is your diagnosis here? Area of consolidation seen, but biopsy doesn't show infection. And patient has recurrent bouts of pneumonia confirmed by migrating opacities. So it's first step क्या था हमने? First step क्या बोला? Is it infection? Is it infection? Doesn't look like ना. So first question ही हमारा out हो गया कि not infection. So तुम्हारी लिस्ट में से एंटीबायोटिक तो out हो गया. अभी बचा क्या है? Steroid and azathioprine. So for that you have to think. So immunosuppression तो नहीं देंगे, recurrence हो रहा है. Steroid because she has a cryptogenic organizing pneumonia. The line of treatment for cryptogenic organizing pneumonia is a prednisolone. So this is how you have to develop. Whether it is infection, first step you have to ask. And if non-infectious, you can wait and you can take help of the maybe other faculty colleague also if you want to treat them. This is the last case. 75-year-old diabetic patient present with 7-day history of swelling of left lower limb, pain, bulla, discharge, recent NSTMI, mild respiratory distress, came with acidosis in the ICU and then was intubated also. So what is your plan for this patient? What do you think? ABG shows acidosis, non-STMI and breathlessness, lactate is high. What do you normally think? So infection, non-infection. Infection is there. So infection is there. You have to undergo two things. One is you have to see the source control also. So we think of infection, we think of source control and antibiotic choice. So what is antibiotic choice here? Diabetic gram positive coverage. So, meropenem.
Amoxiclav or
Amoxiclav ventilate हो गया patient और amoxiclav is good for discussion, but will you really start on amoxiclav? Diabetic comorbidity.
ICU में आए ना
ICU में आए. So which organism you are suspecting? Second step is which organism you are. So you take a blood culture. You are not wrong even if you start piperacillin. You are not wrong if you start meropenem. But you know comorbidity is high. Patient is diabetic. You start a higher antibiotic curve. No doubt you start a watch drug or reserve drug. But take the blood culture and do the early debridement here. Go for early debridement and reassess on the third day. Or you may take help of the additional things, clinical vitals and other things. So this is on the third day now. Patient has improved. You have done the source control. You have procalcitonin, which was earlier 1.5 has come to 0.2. Urea creatinine is improved. Troponin T was little bit high because of his cardiac condition. X-ray, pilar opacities, and now blood culture, urine culture, sputum no growth because you send all as we send. But the swab from the pus was sent, which shows MRSA, Pseudomonas, Streptococcus. So what should be done now? We have a culture report. We have clinical improvement of the patient. So should we stop antibiotics? Should we switch antibiotics? Should we de-escalate antibiotic? MRSA, Pseudomonas, Streptococcus, polymicrobial दिखा रहा है. Is it reliable? Do you want something more information?
Sensitivity report we have to create.
Sensitivity report. So this is multi-sensitive Pseudomonas and methicillin resistant staph. Streptococcus is sensitive. So whenever you send the wound, you have to, the tissue has to be sent. Not the superficial swab may be colonizers. Half of them may be colonizers. So we don't know. MRSA was, he may be harboring MRSA. So that's why when the culture is sent from the OT, ask them to send the, not the swab. Swab is not a good sample. So this patient actually received a pip test and clindamycin and subsequently shifted step down, and then they changed to linid, and then discharge pe they gave azithromycin. Is it the correct way of treating this patient? How many days of antibiotic should be given in necrotizing fasciitis?
21 days.
21 days. That is the myth. Huh? That's what they have done. Linid for 14 and then azithromycin for 5 days, and then the source control has happened. So once the source control has happened, then antibiotic duration will be again 7 days, 10 days, not more than 10 days. So only osteomyelitis if you have underlying, then it will be weeks, months. So you have to see what is the debridement part, whether its bone is involved or not. Then you decide the duration, because most of the resistance will develop during duration if your duration of therapy is increased. So this is important in that, and there is no need of azithromycin. No need. This is just as physician want to give azithromycin. So there is no need. He is already received linid. So this is the interesting paper on short-term antibiotic therapy. For all these, they have done life-threatening cellulitis, CAP, VAP, UTI, intraabdominal infection. So please go through this paper, STOP trial. This is STOP trial, and where they found there is no difference if you continue or discontinue. But in discontinue, there was less resistance, less length of all those parameters were better. And they said that you can go as short as 3 to 5 days also for community acquired pneumonia. So there was no difference between 7 to 10 days and 3 to 5. Nosocomial pneumonia less than 8 days. Pyelonephritis 7 days. We normally go for 14 days. The intraabdominal they just gave for 4 days and source control. COPD less than 5 days. Sinusitis, of course, this chronic osteomyelitis is 42 days. So that is what about duration and dose of therapy. So that's what I have for you.